welcome to the latest video from Balance My Hormones. I'm Sam.
And I'm Mike.
Topic today, we'll talk about keeping it simple. Had a few videos of more complex topics going in depth, but just talking about, what is TRT? I think we sometimes forget, because we've been on treatment, that actually this is quite new for a lot of people. So what is TRT? Like, keeping it right simple, and what do you think?
TRT is the acronym for Testosterone Replacement Therapy, and essentially the concept is replace what you're missing. So when one gets a diagnosis of low testosterone, testosterone deficiency, hypotesticular function or hypogonadism, generally speaking, you would have testosterone replacing what you don't make enough of.
So the ultimate end result is you living initially with low testosterone, right? But like you mentioned, the hypogonadism, that those different things are different causes of ending up with low testosterone.
So if we pick up an endocrinology book, they'll make the distinction between hypogonadism, primary or secondary. So what does that mean? Primary hypogonadism is essentially primary testicular failure. You'll tend to see a higher amount of gonadotropins released. These are signals from the brain that tell your testes to make more testosterone. When you have a massive signal of these coming in and a low signal of testosterone as an output, then that's usually considered primary hypogonadism.
So testicles are the missing link, right? Is that right?
Yeah, think of it like the testes are the factory, and in this factory, they're producing the testosterone, and they'll produce it provided they get the proper signaling. So if the speakers aren't working and the workers can't hear the instructions, or the Wi-Fi is down and they can't receive the signal, then they're not going to produce as much.
Yeah.
And when you have primary hypogonadism, they're getting lots of signal, but in this case, the testes either aren't hearing it, or they're not producing enough for that. They're not responding to the adequate signal.
Okay, so testosterone producing factories, they need a signal from the brain to do their job. But if there's something wrong with the testicles, so I think a good example, when I had this explained to me by one of the doctors, is that if you had a testicular injury, or you had your testicles removed, for example, or you lost one in a trauma, that obviously now the factory is broken or missing, so you would still get a very high signal from the brain, which is the LH and FSH, telling the testicles to do the job, because there's no way of really telling the brain actually stop doing that because we've lost a testicle or something like that. So where the testicles are not functioning properly, they don't have to be damaged. It can be aging, things like mumps, right? The other illnesses can affect testicular function. So primary hypogonadism, the fancy word for it, is when, to put it simply, the testicles aren't producing the factory for testosterone. I suppose sperm count is the same thing that they produce too, right? Is that they're not doing what they should be doing, even though they're getting signal. So on a blood test, usually, obviously there's lots of things that come into it, but a common blood test,
you would see an elevation of LH and FSH, probably 8, 9, 10 or higher, and you see a very low level of testosterone.
Right.
Total testosterone as
lots of signal,
so
not a lot of testosterone.
So that's one type of low testosterone hypogonadism, primary hypogonadism that you look at. There's the other one, secondary hypogonadism.
Yeah.
And that usually entails a very weak signal of gonadotropins, LH and FSH, that could be damage to the pituitary. It's just putting a little signal out, and the testes might be very responsive, but they don't have much of a signal to know whether or not to turn it on. In those cases, you see a low output of LH and FSH, and a low output of testosterone as well.
Okay, so testicles might be there, factories ready to go. All the workers are ready to do their job, produce testosterone and sperm, but no signal coming from the brain.
And just over time, after a man reaches a certain age, the levels aren't quite as high as they once were. And the question is, well, what's an optimal level for that person? Because that person may have had levels of 40, and I've seen on blood tests natural young men with levels of 30 and 40, you know, with other issues, but not testosterone related. And so who's to say some of the older men that come to us in the 30s, 35, 40.
I've seen nearly 50, 47 when a chap came through. Naturally.
Yeah.
I saw a 60 something year old with levels of 35 naturally. He wanted just to get a blood test so that he could be monitored
and have a baseline.
And you know, that's supposedly his levels should have dropped off, right, from age 30 on the natural sort of
but
aging.
there's the catch though, and the catch is they have elevated SHGB levels. Yeah, but SHGB takes some of the fun away from the party in the sense that you've got a nice functioning, you know, testicular output. Testes are doing their job.
Good level of testosterone.
Good level of testosterone, a really good level, but you know, there's something else, and it's the SHGB. It's that binds to the testosterone. So what happens is you get a low output of free testosterone, and that's what really matters is your free testosterone level. If it's low, despite how high the total is, you're not going to feel good, and you may have some of the symptoms related to low testosterone.
Okay, so you actually, so I suppose this is where it goes into the depths and the specificity that the doctor would be looking at from each blood test, but there's actually another layer to it that even if you've got a good output of testosterone, it can all be swallowed up and bound to by too much of this protein, SHBG, protein, sex hormone binding globulin. So one actually may have a very good testosterone total level, but a very low free testosterone. And that's where maybe when some men are tested with just a total testosterone and they have a reasonably good level, then somebody not trained in it might actually say, you know, it's great level, but actually they may have very high SHBG.
Especially in light of symptoms.
I suppose that's where treating the patient and not just keeping everyone under a certain number. But you do see guys with, you know, lower levels that feel quite good, don't you?
Yeah, but it has to be the right amount for the right patient.
Yeah.
This is why we call it bespoke HRT, bespoke TRT, because it really is customized. There isn't a one size, one treatment protocol the doctor will choose. I mean, there are limited numbers of different types of treatment. You know, we've talked about this before, injectables or topicals, this ester or that ester, you know, this many days during the week, once a week, twice a week, 3 times a week, once every 10 days. It depends on you and the doctor what's going to be best. I mean, we've got some people that they don't want to inject, but once a week. They just can't fit it with their lifestyle. And
so compliance again, isn't it?
Yeah, so compliance is part of the picture.
I think, I've had it described to me, it's a process, isn't it? As long as everybody goes through the correct process, you will find what works for you. You know, I think Dr. Crisler always said, start low, go slow. You know, obviously you start at a certain point, and you may reach a point where you feel good, and if you feel good and your levels are low, you know, or lower, you know, I don't know how you want to classify that, but it could be sort of, you know, late teens with a good free testosterone. It could be, you know, it could be a variation of things, a certain amount of estrogen, not too high, not too low. You know, you then find what's optimal for you, and that's where, you know, it has. I don't think there can be too much discussion of like what a definite optimal protocol is.
And it also matters on the context of when you're picking these levels. So if someone says, "Oh, I've got a level of 62 nanomolar per liter," and someone else says, "Oh, well, that's just too high. That's abuse." Let's put it into context, because you could be on the most bog standard NHS treatment, and I would guarantee you that if we tested you within 2 days post injection, maybe even 3, your levels would be 62 nanomolars per liter or higher with that initial injection. But that's the guideline.
You know, I've actually seen that online, reading about the guidance for the old style of use of Sustanon, that it was you were expected to reach something like 72 or something on average at, you know, within that first week afterwards, and then afterwards it would come back down. But I suppose there is that whole, okay, you test, you know, the body, you know, the fact is TRT can never perfectly match
the natural rhythm of the body. I mean,
a single ester like an anthate or cypionate. If you tested it 2 days or a day afterwards, or even a lower level, there is going to be a slight peak. You know,
if you use a topical cream, within the first few hours after application, there will be a peak.
There's no ester, right? So
there's no ester.
But that's the thing, isn't it? Like, if if you input, there is always going to be a bit of a peak. So if you catch it at that point, it doesn't stay there forever.
No.
You know, so I think.
So if you want to brag to your mates and say, look, you know, my level was 62, and you put it on the wall, you know, it's like you said, it's not the level you have at all times. Just as if you were to get a test at your trough, or a few days post your trough, the trough being the lowest level. So if you're normally injecting, let's say, once every 5 days or every 7 days, if you measure on the 7th day, if you're doing every 7-day injection cycle, if you measure on the 7th day, that would be your trough. But you would measure it before you would do your next injection.
Yeah.
Okay.
So you get an idea of sort of where you are across the board on
so
average.
You would see before you're ready for that next injection,
Yeah.
what is your level? Is it too high? Is it too low? And then the doctor can adjust you whether you should go in a day early, a day later, if the dose should be increased initially. So it's very important that you do a trough level. And when you don't do the trough level, then you get doctors that don't, if they were to see you, if your GP were to see you, wouldn't be able to put it into context, because they're just going to see this number and assume that it's static rather than it's actually dynamic, and it needs to be looked at in context.
Interesting. So TRT is when you have a low enough level of testosterone and estrogen that comes with it, because obviously the benefits come from estrogen conversion as well. When you've got a low level of testosterone that is causing negative symptoms, the cause could be a multitude of causes in there, but end result is that you are you're seeking help for treatment of low testosterone.
So there's this area where men have age-related testosterone deficiency, and there are certain symptoms that start occurring once your levels start dropping below 17 in some cases, and then down to 15, and there are different symptoms like erectile dysfunction that come into play. I think that needs to be looked at in order to optimize not just a level, but optimize one's health all around. I think that's where a good doctor can suss out the difference between the two.
I suppose that's the same as if you were really low, even below like reference range that they use. Is some replacement therapies just take you into numbers where you perceive that, so maybe you're like at 7 and then they take you to 12 and they're like, job done, you're in the reference range.
Yeah.
There may be no symptomatic benefit there, but that's where optimizing it for you becomes the optimization sort of description.
Absolutely.
As well.
Yeah. So it has to be optimized for the individual, and it has to be optimized for their symptom relief. Join us on our next topic, which will be coming out shortly, and don't forget to subscribe to our YouTube channel.
Yeah. Share it if you think it's helpful for someone else as well. Thanks, guys.
Okay, thanks.